Today is Friday. We usually have Health Friday conversations, and we want to start the first one today. We're going to be having two of them. We want to look at handling emergencies and health emergencies across Africa. We are joined by the Acting Director of Africa Centers for Disease Control and Prevention, that's Africa CDC, Dr. Ahmed Ouma. How we welcome him, CT?
Well, this is our final proverb from the country of Namibia.
Mm-hmm.
The hunter in pursuit of a lion does not stop to throw stones at birds.
The hunter in pursuit of a lion does not stop to throw stones at birds. Daktari, karibu sana to Kenya's biggest conversation.
Okay.
This is the hot seat of the Situation Room. You deal with the hot situations all the time, so I mean, this is basically fish to water.
Almost.
Almost. This proverb is from Namibia. Does it strike a chord with you? Hunter in pursuit of a lion.
Very much so. I mean, it's what we face every day at Africa CDC, where we would make the lion the really big health emergencies and disease outbreaks on the continent.
Yeah.
And the birds will be the usual conversations on the side, misinformation and anti this and anti that. So when we are focused on chasing that lion, no, we don't stop to stone birds at all. We don't even notice they are birds. Very focused on the lion.
Focus on the big one.
Yes.
Tell us about Africa CDC. I mean, what's Africa CDC and what's the mandate?
Africa CDC is an autonomous health institution of the Africa Union. So our parent is a political organization, and our mandate is prevention and control of diseases on the continent. It's as broad as that. But within the mandate, 80 or so % of our time is focused on health emergencies and disease threats, and creating an environment where all those can be able to be brought under control quickly. Today we are 6 years old. Our birthday was actually 3 days back on the 31st of January. So we are a young institution in that sense. But what we do is big stuff. It is the stuff that many intergovernmental organizations have been struggling to do on the continent for decades now. So we do three big things for the continent. One is coordinating any strategies and response to health emergencies and disease threats. Second is building the capacity of our countries so that they are able to resist the smaller ones. And third is mobilizing appropriate resources. And resources, I don't mean money only. It also includes expertise, it includes institutions, it includes public knowledge. We mobilize all that we need to be able to prevent, prepare, and respond to any disease threats on the continent. So this is what we do.
What constitutes emergencies?
I don't want to give you the academic definition. Let me give you a more practical definition. An emergency is any disease, known or unknown, that overstretches the health system in a particular space, whether the space is a community, a country, or a continent, or indeed globally. So long as it is stretching the health system, then that's an emergency. And an emergency then means we need to come at it differently. We don't use the usual systems and resources. So we bring in extra to try and bring it under control. So long as it stretches what we have, it becomes an emergency.
Okay. What, according to the ACDC, has been the emergencies, let's say, over the last 5 years to date? What are the ones that we can look at and say these were emergencies across the continent?
COVID is the most famous one, and that was global. Second, that has really given us a big headache has been Ebola. And both Zaire and Sudan have strains. And Ebola has been there, West Africa, central part of Africa, particularly DRC, and now on the eastern side in Uganda. That will be 2 on my list. 3 is cholera. And cholera unfortunately, is one of those neglected emergencies. Because until it starts affecting a lot of people is when you see the reactions coming through, not when the numbers are small, but been a very big emergency. Fourth is the two fevers, Rift Valley and yellow fever. And I say the two fevers because they affect animals and human beings more or less similarly and at the same time usually. And then we have the next group, which I'll just list, and that will be Lassa fever, that will be Mpox, before we used to call it monkeypox. These diphtheria, these measles is an ongoing one. But from the Africa CDC standpoint, the ones where countries don't have good capacity are the ones that we really, really focus on. And these have been the big four, and that is COVID, Ebola, cholera, and most lately has been Mpox.
How would you say the operations of dealing with them then? Obviously, acknowledging them and saying what the world has been able to do, especially with COVID. But then how has this Africa CDC been able to then work to handle this? Ebola, we had that 2014 period again, and then it came about a couple of years after that. And then just before COVID came, we're trying to still handle the last parts of Ebola. How would you say this has been handled? These emergency diseases, these ones that have been given emergency status, have been able to handle them?
Let's separate the time before Africa CDC and the time after.
Yes.
Africa CDC. 2014, 2016, Ebola in West Africa, there was no Africa CDC.
Yes.
In fact, that was one of the catalytic moments for the continent to establish its own Africa CDC. So before that, there was a lot of players on the continent before Africa CDC that were doing emergency support. They're still here on the continent, but not very coordinated. And certainly if there is any coordination, it will be only in the country that is affected. The neighbor, very little, if at all. After Africa CDC came into being in 2017, then our first role was to coordinate all that on the continent. And you see there is a distinct difference between a period when there was no coordination or little coordination and the period where there was statutorily coordination by Africa CDC. So what we do whenever there is an outbreak anywhere, 3 steps that we take. The first is to work with the relevant government or governments, because some of the outbreaks go beyond one country, to establish a local plan for response. That will be build capacity, get the right tools in place, and then deploy wherever it is that you need it. Second is make sure that cross-border negotiations are going on and agreements, because viruses, bacteria, all pathogens, they don't need visa, they'll cross so long as the human being is crossing. So we establish that cross-border mechanism so that there is nothing that is allowed to spill over if we can be able to help it. So that's the second bit about just strengthening systems locally and across border. Third is then we put a coordinating mechanism for the whole continent, so that although Lassa fever is in Nigeria, we have a coordinating mechanism that involves countries on the other side of the continent, so that they understand it and they can be able to act on it if at all it will be necessary. So these are the 3 steps that we take as Africa CDC, and it has worked. It has worked. I'll give you an example. At the beginning of COVID, there were predictions from elsewhere in the world that, Africans will be dying in the streets.
Yes.
And to date, we have lost, very unfortunately, just over 256,000 people. Their prediction is that will be the number literally every month. It didn't happen because we coordinated, we built our capacity, and then we responded together as a continent. So we are very proud of what we've done over the last 6 years, because the results are there to be seen. There's no outbreak that is big. Ebola in Uganda since September. Again, the prediction was because it is the Sudan type strain, or we don't have rapid diagnostics for it, we don't have vaccines for it, things will go haywire. It didn't. Because we did what Africa CDC was established to do. And Africa works.
What
when
did
we
you
want it
do
to work.
actually? Give us this practical example, because we're right across the border.
Yeah.
And even the government of Kenya had already issued alerts like, be on the lookout, there is this strain of Ebola in Uganda. And then just the other day we heard the Ugandan government saying it's been contained somewhat. What did you do as Africa CDC?
And not just Africa CDC, what the full team did is there are four major things that were done for this particular outbreak in Uganda, which is a reflection of the lessons that we've learned, not just from West Africa, but from all other outbreaks on the continent. One is to get the government to be in the driving seat. Don't let partners run around the country doing their own thing. The government has a plan, and all of us who are supporting the government are following that plan. Development of that plan, we all contribute because there's different experiences and knowledge and expertise. That is one. And the government of Uganda took the driving seat, and I must congratulate the president there, the Minister of Health and others. Second is bring in the right people for the response. Before, it used to be a lot of expatriates coming onto the continent as expats. But are they in the field? No.
They're not.
If you go to West Africa, the history there, we had thousands of expats, expatriates that is, but they were all in the hotels, not in the community.
Yeah.
And so what we've done is making sure that the right experts are deployed and they go to where the problem is. So you don't go and sit in Kampala, go to Mubende, all right, and the center of it, and support the system there. Third is providing evidence for what we do. Before, collection of data, analyzing it and feeding it back to policymakers was not as efficient. Today, there's cholera in Malawi now, even in Kenya. We analyze on a daily basis. So at the end of each and every day, as Director of Africa CDC, I must be given the situation from the teams of each and every outbreak on the continent, and we grade them, and then we respond to them on a daily basis. That happens. And then finally is making sure that we have the full backing of our policymakers. Some are politicians, some are technocrats, but we must get that backing. And that backing can only come if we go with evidence. And we say this is what we need and this is when we need it. And we push for those resources to be able to be released to us. That way we can be able to work. If that had happened in West Africa, the Ebola crisis then would have been much shorter, as all the others that came after it have been short because Africa CDC has put these new mechanisms into place.
What does the coordination look like between Africa CDC and governments? Because, I mean, one can only assume that it would be impossible to do the work that you do without the input and participation of states. What does that look like? What does that coordination and relationship look like?
So we have coordination at three levels. The highest level I'll come to last. The middle level is one I'll start with. And this is where senior experts come together to do the strategic thinking. What we do with governments is as soon as an outbreak has been identified, then we sit with their senior staff and our senior experts, and we come up with what can work. That's where we start. And we agree on that. And we don't move as Africa CDC until and unless a government agrees. All right? Then we go up to the principals now, whether it is the minister or the head of state, and we let them know clearly this is what needs to be done. And that's where it's very nice to be on the Africa CDC side because we can say things frankly, but of course not in the studio, so that they understand the situation. And they know the decision they are taking, what the effect is going to be. And frankly speaking, our heads of state, they listen. When they get good advice, they actually listen. And it has been like that for us, each and every outbreak that we have faced to date. Then we come to the lower side, now the responders, the me and you who are out there in the community. They too work very closely with government staff so that whatever we are doing and the government is doing, if we separate it and this one goes to that village, that one goes to the other village, it's exactly the same thing. At the end of each day, the team on the ground, again, they regroup, they compare notes. And then all that is then escalated up either to myself or my team and then to the minister at country level. That way we are always on the same page Our data is the same. Our strategy is the same. Our requests to our various constituencies are also the same. If you don't work closely with government, you will not succeed. And that's why many of institutions that have been on the field for a long time have not managed to go through that, because they want to do things on their own because they feel the government is slow. Governments are slow. It's a huge machinery. But you work with it. I would rather I was going at 20 kilometers per hour instead of going at 100 and I'm alone. All right? Because then you don't reach safely. A vast majority have been left behind. So that's our modus operandi. We work with government and we try to increase their speed the best that we can, but we must work with government.
How is Africa CDC funded?
Core funding comes from member states, and member states are African countries. We have 55 of them. And that core funding then runs the core staff, it runs our core operations, and it runs part of our program. The balance of the programmatic resources comes from partners, and we have partners across the world, and including here in Africa. We've changed our model, and we are insisting on working with African private sector, African philanthropies, African public, so that we start the resource mobilization locally. But all in all, about 40% is member states, and about 60% it then comes from partner mobilization.
You did mention at the beginning of this conversation that when a health system is overwhelmed, you then can easily state that you have an emergency. Now, there are those who argue that perhaps if attention was paid to primary health care, or more specifically the preventative aspects of health care, some of these emergencies would either be lessened or eradicated altogether. Now, what is Africa CDC doing in pursuit of these specific goals?
That statement is fact. If we focused disease, outbreaks, emergencies, they start and end at the community. That first case will be in the community. That last case will be in the community. And everything else we do in between, we'll have to engage with the community. So if we handled our engagement with communities more efficiently, more effectively, we will not stop bacteria, viruses, and other pathogens from infecting us. We can't stop that. Eradication is possible, but so long as there's that one virus hiding somewhere, there's always a risk that it will be able to blow up. It is what we do. I'm not afraid of outbreaks. What I'm afraid of is what we do when it occurs. Because if we do the right thing, then it becomes small. It's the first 2-3 cases, we arrest it. If we don't do the right thing, it becomes hundreds of thousands affected across the continent. So the communities are our source of information, and they are our actual soldiers on the ground to stop a particular outbreak from happening. Primary health care has been discussed and talked about for a long time, but relevant action is not being resourced so that the communities can actually be empowered to take care of their health. Let me give an example with West Africa. I'll not mention the country, but one of the 3 countries where Ebola was. There's one community that decided they wanted to understand it. And within the community, they formed their own buffer, a village, where you don't enter unless they know who you are. And if you enter, you must get tested. Right? That community was not overwhelmed, neither did they have many cases. There were very few. Because the community participated in that. So the boda fellow, the taxi driver, the matatus in that place, they will not carry you if you're a stranger. And if you are a stranger, then you'll be delivered to a place where they know you will not be able to have their community exposed. But we take, unfortunately, the community very lightly. And we engage them only when we are giving instructions. And it doesn't work like that. Human beings are best engaged when you have a discussion, not when you have instructions. There are moments for instructions, though, and those are there in public health. But the best is that conversation you'll have and you communicate. So primary health care is the core of ensuring that when an outbreak occurs, it is small, it is contained, and we learn from it so that the next one will be even smaller and contained even faster. The resources must be in community engagement.
Have you seen that the footprint of learning then has spread? The unfortunate thing about an emergency is that once the emergency time passes, human nature then obviously forgets sometimes. But do you find that learning actually occurs and that this primary healthcare practice that we speak of then becomes resident amongst communities? And if so, how do you then measure and say, actually, so we had this emergency, this is what we're able to do to mitigate. The time has passed, but then we have communities having been buffered, and then they know what to do in the case of another emergency, whether it's a disease that's known to them or not, but at least basics have been established.
Yes. We have seen transition from very minimal engagement with the community to near optimal engagement with the community. And we have ways of measuring that. One key indicator for us is the presence of community health workers or community health volunteers, whatever you want to call them, in the community. Because while other parts of the world have mobile phones and apps that can trace your movement and who you were exposed to, our app is actually the community health worker. Where you find community health workers have been well facilitated, the indicators in that community dramatically changes. Where there is no way of smoothly getting information from the community to the authorities, then you don't get the indicators being very good. And for me, if there was one measurement that I would go around checking, it is, do you have community health workers? Not the one nurse in the dispensary that is serving 10,000 people, but who in the community is actually engaging with the population on a regular basis, right? And not to wait to do it on a programmatic basis. Now, today is HIV, tomorrow is TB, the next day is measles. No. Community health workers, the best is to have them pass information irrespective of what the condition is. I mean, it could be things away from health like rains have been predicted to be heavy this season. The community health worker engages with the community that, look, when there's a lot of rain, these are the things that we need to do so that we can avoid these other things in advance. You don't wait until the mosquitoes have started biting you and then you start looking from kebe to poke and so that it can not hold water. No, you do it in advance because it is cheaper, it is faster, it is more efficient. And communities which have community health workers that have been well facilitated, the indicators are way different from those that... In fact, 3 weeks ago in Davos, I will not mention the country, but a senior official from a particular country came and said, Africa CDC, you've done so well with community engagement. We are not able to do as well in community engagement in my country. And I was telling that, look, the situation is different. We live in a community. In the global north, you don't live in a community. Yes. You don't know your neighbor. Yeah. So which community health worker is this that's going to be knocking on doors of people they don't know? It may as well be me from Africa doing it in your country. So we have a huge advantage as Africa because we live in communities. And if we get community health worker part right, the indicators are going to follow that investment.
Time for the break. Yes. They're given a stipend. There are very many in the community. In fact, she was talking about in terms of the reach that they have, she was boasting that they have the best. Now, very many other counties have similar conversations. We have community health volunteers, we have community health workers. Some you'll hear conversations about community health volunteers just being engaged at some point during immunization drives. The other times, we don't have money to pay for their stipend. Sometimes you don't have enough money to pay them on time. At national level, Daktari, you've worked in the Ministry of Health before you went into private sector and also went into Africa CDC. We have a directorate for preventive and promotive care. Looking at all this and the conversations that happen, one asks, why is the issue of a community health worker considered like a support or a secondary issue when it's a primary health issue?
Difficult questions. I wish you had asked Muga that one. But look, the perception and I call it perception because it's not fact, perception of a community health worker is the one that is currently not spot on the money. A community health worker is the beginning of the health system. And if you don't have community health workers in our context in Africa, then your health system has not begun yet. The next step you will have are curative facilities. So you are starting to attempt to cure. You have not started the health system. If I was to give advice to both levels, both the national level and the county level governments, in as far as health is concerned, it will be invest in community health workers, community health volunteers, whatever you want to call them, and get the communities to always receive the right information. I'm glad Ouma Bay is doing something about it. I'm from Ouma Bay. Next time home, I'm going to check that things are flowing well. But if we don't get the two levels to speak the same language, invest together, then we'll always have gaps because programs will come, do their bit, and then leave and not have it as part of their regular budget at the county level because they're responsible for health, and at the national level in terms of policy, capacity building, and support to the county level governments. So it is a perception that is, in my view, not spot on. And as soon as the lens is shifted so that they focus on the health system, and the beginning of it is the community health volunteer, the community health worker, investment will be made there. Unfortunately, our partners from the global north don't see that. They don't know what community health work is. Well, they know it in politics because they campaign, but they don't know it in health. And many times you'll hear institutions from outside saying, a wage bill is too high, so cut it. And you want to cut it on community health workers, meaning you're mutilating your health system. Why would you do that? And there are creative ways of keeping the community health workers in having their stipend and therefore doing their work, rather than just looking at it as a pure wage bill. So that fiscal space discussion must be looked at and discussed, and this is what we tell IMF and World Bank all the time. Look at it from the context of public good. Sure. If you have your figures are good and your population indicators are bad, what's the point of having good figures on the balance sheet? So flip it. Make the population's indicators good, and then we discuss what the figures are going to look like.
Those populations indicators, I mean, whether we're looking at it from an Africa umbrella body CDC position or from a government position, a state's position, I think it's important to look at what a community health worker could actually do when we're talking about an emerging disease and a disease that is at emergency status and then trying to curb that. Whether we're talking about disease surveillance, because these folks are living in the communities, they're seeing things. Would you rely heavily on them to say, hold on, something is popping off here, report it back, or certain symptoms that we see because you're already in the community and you've been tasked with this job of, keeping your eye out or being on the radar? What exactly do they do that could give rise to now this explanation?
There are two sources of data, actionable data for the health system. One, which is the most prevalent, is me, I'm sick, I come to the hospital. Then I'm diagnosed, it is put in that book, someone puts it together and we say, okay, now we are seeing malaria or whatever other cases they are rising.
Yes. Yeah.
That has a lag time of usually a month at best. Many times it's 3 months. The flip side of it is a community health worker. That's the other possibility. And it has worked for us. But the Ebola in Uganda, we had village health teams that were doing this work. It was fantastic. We knew within hours that something was popping in a particular community. Now, we as Africa CDC are advocating not just for community health workers, but also they're giving the right tools. And we have a program now that we are just beginning. I don't want to call it pilot. We are beginning to implement, where we are giving community health workers gadgets. And on that, is all the information that they need. And it is a very basic gadget. It's not a smartphone. It uses GSM. Then they let the center know in the country what's happening in their community. So someone sitting at the Public Health Emergency Operations Center, and that's another discussion we need to have, will tell that village X in Homa Bay, village Y in Migori, village Z in Kisii are reporting similar things, right? And that information comes. Our intention is that within 6 hours, at the very most, the top policy maker for health, the Minister of Health in a country should know. As Africa CDC, in 7 hours, we should know.
Of one case, for example?
Whichever cases. So long,
Whatever.
no, not one case. So long as there is a pattern.
There's a pattern
If it is one
developing.
case, we expect the health system in the country to take that over. But if it is a pattern of, let's say, a hemorrhagic fever,
Yeah.
people are coming in with this and there are 3-4 of them, we should know. Because we want to act before it becomes an emergency. It is an outbreak, and outbreaks are fine. We deal with outbreaks. But it should not escalate to be a health emergency. So within 6-7 hours at Africa CDC, we should know.
Okay.
That means that by the next day, we'll have a team of experts to support the government to keep it in Migori, Ouma Bay, or Kisii, whatever it is, in a small...
Keep it tight.
Yes, so that it does not spill over and start affecting all our lives. Unfortunately, you guys are not wearing masks. You've forgotten COVID. So we do the right thing as a population. If we don't do the right thing, then Tanzania starts getting jittery. Uganda, your neighbor, starts getting jittery. JKIA starts losing focus. We
Hunting.
need to keep it tight, and that's where the community health workers become important.
Can I ask this question? It's all important. You understand it. You're probably trying to preach this gospel to the governments on this continent. But to strengthen this cadre of worker, should we then not have a standardized training? Formalize it, meaning, just like you went to an institution where your training was formalized, and that is why you can go to any part of the globe, and people understand that you do qualify for the title that you have because you're able to do certain things, standardization. Is it possible? Can we make the training of this community health worker standardized so that we institutionalize it? And even as they've been working, they can upgrade so that they actually get trained. So you know, when someone is called a community health worker, you know this person has the capacity to do this and this and this and the other.
Yes and yes. Yes, there is need, and yes, it is happening. It is slow, but it is happening. As Africa CDC, 3 things that we've done. One is our heads of states have already made a decision 3-4 years back that community health workers, we need to have at least 2.5 million of them by 2025 active in the communities across Africa. So we have the political mandate. Second thing that we've done is all the organizations that are participating in community health work, and there are many on the continent, we are working with them to standardize the training. All right? So that you don't get these little bits of 2 days and then you're taken to the community. No, that doesn't work. So we are getting to standardize that, including the amount of time and the range of information. And very importantly, how do they get new information infused into their work? So that is happening. 3 is we are already doing with the institutions that are already doing community work. AMRE, for example, here we are working to ensure that we are digitizing the way the information is flowing back. Because it is one thing to have a good community health worker well trained in the community, but if their information will take you 3 months to get because it is on a piece of paper, then it doesn't work. So those 3 things: we have the mandate. We are standardizing the curriculum, including upgrading information, and then we are digitizing information that comes from the community back to us. So that those 6-7 hours I'm talking about, we want them to be a reality.
As information is coming back to you, it means that you need to be present, right? Do you have offices in every country, that every health ministry in each member state?
No, and we don't need them. COVID has taught us that we can work from anywhere. And even during lockdowns, we didn't go under lockdown as Africa CDC. We worked throughout, so I don't know what lockdowns are. But we don't need presence in each and every country physically as an office, because an office takes money to run. What we do as Africa CDC is our structure is there's a secretariat based at the Africa Union Commission headquarters, and then we have 5 regional offices. The eastern one is actually here in Nairobi. And then we have in Lusaka, in Libreville, in Gabon. We have in Abuja, in Nigeria. And then the North African one is coming up soon. We are still figuring out where we'll place it. Those regional offices then have Africa CDC focal points in each and every ministry. That's they engage with. The focal points are government employees. We just make sure that information is reaching them carefully. From my office, we are linked with each and every Minister of Health, so that if something needs that kind of speed, then we go above that and we make sure that the principle is known. If something is technical and it is the regular work that we do, the focal point in each and every ministry is engaged. Now, when we have these linkages working, and it doesn't work everywhere, not yet, when we have those linkages working, our response is very, very efficient. We don't need to be at country level. Where there is a problem, cholera in Malawi today, we send a team. And that team's job, 3 things. 1, help the government to set itself together. 2, for us, very important, is build the capacity of local experts. The day we leave, today in DRC, we don't need to go. If there is an outbreak of anything, I send 1 person to go and do the coordination. Because we built the capacity in that country over time. And that's what we intend to do everywhere. It costs 1/10 to have a local do the work instead of sending me and putting me on per diem of a few $100 every day to sit there and do what. So we build the local capacity, then we don't need to send anybody on the ground. And that is the team we call the African Volunteer Health Corps. They are rapid responders, a standby force. When we need them in their country, they are there. If that country doesn't have trained ones, we take from the nearest country. They go, they build the capacity, and the next time we don't need to send anybody. Uganda, we don't need to send anyone next time because we built that capacity.
Sure. As I think about the kind of diseases we talk about, that we've been speaking of here that would be emergencies, they seem to be the infectious ones. Cholera, Ebola, COVID. We see the report of the cancer survey for Kenya, for other African countries as well, that burden rising quite significantly in the last 5 years. Is this something that Africa CDC is involved in, and how? Because, I mean, it's not an infectious disease, but it is an emergency in many countries.
Yes, and in the beginning I'd said our role is disease prevention and control. And although about 70-80% of our work now is responding to disease threats and emergencies, our role is broader. The reason why we are chasing all these emergencies is because they are acute. Africa CDC has 2 relatively large departments that deal with non-emergency issues. And one is called Disease Control and Prevention. The other one is the National Public Health Institute. Our role in the non-communicable diseases, and I'll add to that environment as well, is to bring up our continental response to emergency level. Today, diabetes is an emergency.
It is.
Cancer is an emergency, and so is our heart diseases. But we are not treating them as emergencies. In fact, we are treating them purely as curative sessions.
Yeah.
You are sick, come. I look at you, poke you with something, or I give you some pills, you go home.
Yeah.
That's not it. It is an emergency because we have a triple burden of disease. Communicable diseases, non-communicable diseases, and then injuries, road traffic, violence, etc. And these 3 are syndemic on the continent. Our work is now, we are progressively moving away from looking at non-communicable diseases and injuries and such, not as the usual, but we are making them emergencies. So we're using exactly the same design of responding fast and going to the very top. And when we discuss with the principals, the information we get back sometimes is quite surprising because they don't see it as an emergency because the data is not being provided to the minister, not to the heads of states. We are very busy pushing malaria data. We are not pushing diabetes data. There are more diabetics in this country than people who suffer from malaria. Sure. Now, if you go and look at the malaria program and the investment, and then the investment in the diabetes program, you can't compare them. That's wrong. So we are using that data to tell them this is an emergency. If you already graded this one as an emergency, this one is also an emergency, and this is what you need to do. So we are doing a lot of non-communicable diseases. So part of the reason why I came to the Cancer Summit, so that we can be able to pass that message clearly that this is also an emergency.
How do you? Sorry. No. Please. I insist. Go ahead.
Ladies first.
Yes.
Sure, all right.
Only in public.
How do you deal with the uptake, or unfortunately, lack of uptake of some of the suggestions then you make to governments? Because I mean, you've said here now vehemently this is not right, because we can see that this is form of practice. So you can suggest this, you can say, look, this is necessary for you to do. See this as an emergency. Many would complain that, no, not many. It's been said in Kenya, for example, that depression, which is a psychological issue, but is emergency status in Kenya today. Nothing has been done about it. And we can say that very plainly, that nothing has been done about it. So you can make these suggestions. You can come and have these conversations with the principals. How then do you deal with, all right, we take your suggestion and we're going to hold it for a minute while we focus on other things. How do you deal with that?
When I was at the ministry, I'll not say which minister it was, but when I was at the ministry, I was advised. I was relatively young and very passionate about my work. I started the Department of Non-Communicable Diseases when I was there, and I really wanted something pushed. That particular minister told me that, Dr. Ogoel, you're my advisor. You advise, and then I decide. So I have many other pieces of advice that I'm dealing with. So yours joins
the queue.
And I appreciated that. Our role as Africa CDC is advisory, and then when we are given the go-ahead, we respond. How do we deal with it? Many times I go home and I can't have a good meal because I know we need to do this, and yet it has not been done, especially when the situation is across countries. One country is willing to do it, the other country is slow. You live with it, but you don't stop knocking on that door. So on my phone, the ministers I call the most are either the ones who are very engaging or the ones who are not. Those are the ones I call the most. And you want to make sure your message is being heard every day. Even if the point will be, we are menisumbua sana, okay, go and do it. It's okay, because I'm going to do it. But it's very, very difficult to deal with when you know this is right and it is not your decision that it actually starts getting implemented. But we don't give up. We continue, we press and press until we get some movement for the continent.
It is said that some of the partners that we have on this continent from the West come in with their partnerships, but also with their own interests. How does Africa CDC marry their interests with that of these external partners that they have?
Muga, there's no free lunch. And everyone who comes to help with, there's a reason for that. Even if it is as basic as their parliament passed a certain budget which was meant for a certain thing. But the way we do it at Africa CDC, and we have something we call the new public health order. Everything that we've learned over the last 6 years have persuaded us that the structure of health security globally is not good for the African continent. Our new public health order has 5 pillars. The first is strengthening our institutions. If we have institutions that are ready to act, then those outbreaks will become small. Second is institutions at national level and at continental level. Continental, of course, Africa CDC, the Africa Medicines Agency. National level are the agencies responsible for health security and health emergencies. Second pillar is strengthening our health workforce. We must train the right people in the right cadres, give them the right tools, and then deploy them to the right place. You don't want to train community health workers, then you've not paid them, and so they're sitting home. You don't want to train epidemiologists, then you've deployed them all to Nairobi and the other big cities, and there are none where they are required. Third pillar is local manufacturing. There is no way you will do effective health, security, preparedness, and response if you have to wait for other countries to manufacture for you masks or vaccines. It doesn't work like that. So local manufacturing is essential. Fourth pillar is resource mobilization, domestic resources. We have enough resources on this continent to be able to act quickly before partners come and help. But we're not mobilizing the resource. The private sector is not engaged. The government portion is small. The public are not part of it. Philanthropies are not fully engaged in the continent in health security. Fifth, and this is where now the partnership is partnerships. And partnerships for us must have 2 characteristics. One is they must be action-oriented, giving results, and 2, they must be respectful of our priorities. So the way we deal with our partners is from the beginning of the discussion, is it covering an African priority? If it is covering an African priority, to go to the next step. When you go to the next step, it is who is going to do the implementation, and we insist it must be Africa CDC and its local implementing partners. Whatever other interests you have, if it doesn't fit with ours, then we cannot be able to proceed.
Dr. Ahmed Ouma, thank you for joining us today.
My pleasure.
When next you're in the country, please come. Stop by,
Anytime.
visit. Always a pleasure to have a conversation with you.